In 5, 4, 3, 2, 1. We are live now.
Hi everyone. It's my pleasure to introduce this joint Assi and Posi program on early onset scoliosis, as a prelude for the ASSICON 24. And we have a great, faculty who are making time for this program. I'd like to ask Dr. Chahal to initiate proceedings. Thank you.
Good morning. Thanks, Arjun. On the behalf of the Association of Spine Surgeons of India, we welcome to you a joint outreach session with the Pediatric Orthopedic Society of India. It's a wonderful society. On a personal note, since I am from Manipal and I have been associated with all the stalwarts from Dr. Benjamin Joseph to Dr. Sriram, and Vijay Sriram is a very close friend. And my first poster presentation in any conference was in Posi, Delhi in 1999. And it's a wonderful society doing excellent work. And this program has been designed in such a way that it benefits all of us. This is a very, very important topic touched by all orthopedicians in their practice. So I welcome you all to a wonderful session.
Good morning to everybody. On behalf of the Bombay Spine Society, which is the host society for the ASSICON 2024, I invite all the speakers and all the delegates to this session on early onset scoliosis. It is a very dear subject to all spine surgeons as well as the pediatric orthopedic surgeons who deal with deformities. This is, in fact, ASSICON before the ASSICON, because these outreach programs are so nicely curated that it will have wealth of information which will be available to the delegates even after the event, because it is being recorded. I hand over the proceedings without much delay to Dr. Johari to start the program.
I would request Dr. Alaric Arujes, who is the president of Posi, to say a few words before I formally take on the program.
Yeah,
Thank
sorry,
you so much,
I didn't see him. Sorry, I didn't see him in the...
No worries, Ketan.
Welcome, Alaric.
Good morning, everyone. I'm Alaric Arujes. I'm the president of the Pediatric Orthopedic Society of India. And along with my co-host and secretary, Dr. Viraj Shingade, I welcome all of you to this joint webinar between the Association of Spine Surgeons of India, the Bombay Spine Society, and Posi. The vision of Assi and Posi are closely aligned, and that is to provide educational opportunities to its members in the form of conferences, webinars, CMEs, fellowships and scholarships for our younger trainees, with the ultimate aim of improving the quality of care we provide to our patients. And in this essence, I feel that this webinar is the right step in that direction. We have a whole bunch of wonderful faculty who have spared their time and their expertise to share their knowledge with all of us. And on behalf of Posi, I welcome all of you to this excellent webinar. I hand it over to Dr. Ashok Johari for introducing the moderators and the speakers for this session. Thank you all very much.
Well, thank you, Alaric. Thank you to both the ASSI and Posi for hosting this webinar on a subject, which is very dear to my heart. We're going to be speaking on early onset scoliosis. And talking of early onset scoliosis, it's a problem of the growing spine. This is a child I saw end of 1987 when she was born, with a Cobb angle of 30 degrees. And by the time I saw her a second time in 1989, a little more than a year's interval, the curve magnitude became 86 degrees, And this is not unusual, You have these patients, this is a 5.5-year-old child with a progressive deformity. The scoliosis measures 115 degrees, the kyphosis is 70 degrees, So horrendous looking spine, young age, how do we treat, progressive curves, things getting worse? What are our treatment options, The deformities of the young spine can be due to a number of causes, which are mentioned on the left. So early onset scoliosis is a miscellany of different ages of onset and different etiologies. Spinal deformity present before the age of 10, regardless of its etiology, falls under this bracket, that's early onset scoliosis. Why is this different or distinctive? Because it has an increased risk of progression, increased cardiovascular compromise, increased morbidity and mortality, and treatment is difficult. There are many strategic factors which the speakers will outline. I just summarize these, right from age and etiology to the physical status to number of surgeries, psychology and the quality of life. All these are involved. The numerous speakers today are going to sort of enlighten you on these aspects. So we will be starting with Dr. Ashish Ranade. He is going to be speaking on pathogenesis of early onset scoliosis. Then radiological features and MRI findings in early onset scoliosis by Dr. Naresh Babu. Casting, indications and technique, again a very important form of treatment in early onset scoliosis, Dr. Shyam Kishan. Growing rods, when and how, Dr. Salil Upasani. Hemivertebrectomy and fusion, Dr. Ajoy Shetty. Complications of surgery, Dr. Abhay Nene. And then a special category, that is syndromic scoliosis, special considerations by Dr. Bhavuk Garg. Now, after all this, to apply what we have learned, we will have some case discussions, and Dr. Arjun Dhawale and Dr. Naresh are going to lead the case discussion. Now, a brief introduction to the speakers. I'll just run through these slides. Let me tell you, they're all distinguished personalities in their fields, and it's a pleasure to introduce all of them. Dr. Ashish Ranade is based in Pune. He has had a fellowship in pediatric orthopedic and scoliosis. I think he worked with Randall Betts long ago. He is consultant orthopedic surgeon at Dinanath Mangeshkar Hospital and a visiting pediatric orthopedic surgeon at Bharati Vidyapeeth Medical College Hospital, Pune. He is also author of a book on infection, musculoskeletal infections. So he will be talking to us on pathogenesis of early onset scoliosis. Dr. Naresh Babu is director and chief spine surgeon of Mallika Spine Center in Guntur. Again, a very applauded spine surgeon with numerous national and international awards and fellowships. He is secretary of the Association of Orthopedic Surgeons of South Indian States and of the Spine Society of South India, and has held many other positions. So he's going to speak on investigations and MRI, etc. Shyam Kishan, a very own boy, MBBS from JIPMER, and then worked at the State GS Medical College in KM Hospital, Mumbai, before he moved on to the US to establish a shining career. Well, he's director now of pediatric orthopedic surgery, trauma and scoliosis in Dallas, Texas, and professor of orthopedic surgery at Burnett School of Medicine. His special interests are pediatric spine deformity, early onset scoliosis, and thoracic insufficiency, limb deformities and fractures. Dr. Salil Upasani is professor of clinical orthopedic surgery and director of pediatric orthopedics and scoliosis clinical fellowships. He is also director of the 3D Innovations Lab. He is based at San Diego at Radish Children's Hospital, and he is professor at the University of California, San Diego. He is going to speak to us on growing rods. Dr. Ajoy Shetty works at the Ganga Hospital, is senior consultant there, and is currently the AO Spine India chairperson and chair of the Education Committee of ASSI and also of the Asia Pacific Spine Society. He holds many editorial positions. He is associate editor of the Journal of Orthopedics and Journal of Musculoskeletal Disorders, and also on the editorial boards of the Asian Spine Journal and the Indian Spine Journal. Abhay is a well-known personality in Mumbai. This handsome person, besides spine surgery, has many other interests. You see the last part of the slide, it says moonlight, whatever that means, with classic rock band, the Flunkies. He enjoys cross-country cycling, mountaineering, and road running. He's a dynamic spine surgeon, a very busy spine surgeon actually, and was AO Spine Asia Pacific Chair and AOSAP Educator of the Year in 2018, connected with many hospitals in Mumbai. Dr. Bhavuk Garg, who will be joining us as professor in the Department of Orthopedic Surgery at AIIMS, New Delhi. Again, a very academic person with numerous academic awards, fellowships, and publications and presentations. And he is chair of the CCOT Spine Committee. His interests are complex spine deformities, and he has had many original contributions and innovations. He is Associate Editor, Indian Journal of Orthopaedics, Journal of Clinical Orthopedics and Trauma, and the NASH Journal. So now I'll hand over to Dr. Ashish Ranade, who is going to be speaking to us. He's the first speaker. Ashish, over to you.
Good morning. Thank you, sir, for the introduction. So I'm sharing my screen. So I'll be briefly discussing pathophysiology of the early onset scoliosis. So as discussed earlier by sir, it's a problem, and we try to look at some of the normal developments of the spine and pulmonary function and discuss how EOS affects respiratory function and explain mechanisms by which the lung function is affected. So as we all know, it is more than 10-degree curve in a child at less than 10 years of age. The etiologies are varied and they contribute to the pathologies, and it has effects on the development of the chest wall and the cardiopulmonary function. And it is just not an orthopedic problem, and there is more to it, and it's a complex scenario. So why do we need to know about the pathophysiology? All of us agree that we need to correct the deformity when it's a progressive deformity, but fusion surgery is not an option. And growth rods, they have their own set of problems. So the pathophysiology will help us in choosing the correct treatment when we take it into consideration. So etiologies are varied, congenital and neuromuscular, and it is taken into consideration because the rate and the risk of deformity progression will depend on the etiology of the scoliosis. And it's also the part of the CEOS classification system, in addition to the Cobb angle and the maximum total kyphosis and the progression modifier. So brief overview of the spine growth. The growth of the thoracic spine is maximum rapid during first 5 years of life. Then it decreases, slows down a little bit, and then again there is the adolescent growth spurt. The alveoli, they multiply rapidly during first 2 years and continue to do so at slightly slower rate up to 8 years of age, and thereafter the growth of the alveoli ceases. So if we look at the growth of the spine from T1 to T12 segment, at birth it is approximately 12 centimeters, and this increases to about 18 centimeters by 5 years, goes up to 22 centimeters by 10 years, and in adult it is approximately 28 centimeters. So this 22 centimeters of T1 to T12 segment, many authorities, they consider this as probably a point where they can consider whether to go with growth system or definitive system. When we take into consideration this growth of the spine with other parameters, as shown by work out of France by Demiglio and all, even though the growth of the sitting height or the thoracic spine is maximal during 5 years, the thoracic volume is not matching that growth. So approximately 1/3 of thoracic volume is achieved by 5 years, and the T1S1 volume is also approximately 35%. So this needs to be taken into consideration while planning treatment. So pulmonary growth is non-linear. The alveolar capillary proliferation is maximal during first 2 years. And here is a chart when the total number of alveoli against age, we can see that it is maximum during first 2 years, then kind of slows down, and approximately after 8 years of age, it plateaus. So during first 8 years, whatever pathology is developing, that is that can have profound effects in the future. So what are the pulmonary pathologies in EOS? we exactly do not know how common is thoracic insufficiency in children with EOS. That is because the definition of TI is variable depending on literature we are reading. However, the common pathophysiological processes are restrictive and obstructive lung diseases. So the restrictive lung disease happens because of reduced chest wall compliance, which can be because of the deformity and possibly reduction in the lung compliance. The child will present with tachypnea with activity. There will be easy fatigability with exertion. The way to measure it is reduced if we see with normal force expiratory volume 1 and by measuring total lung capacity. But having said that, these pulmonary function tests are not possible in young child, and so that remains problematic. Also, because of the restrictive lung disease, there is reduced maximum expiratory pressure, and the MEP is reduced to a greater degree than the maximum inspiratory pressure. This reduction is further aggravated by underlying neuromuscular disorder, such as spinal muscular atrophy or Duchenne or cerebral palsy, especially GMFCS 4 or 5. So this decreased respiratory compliance leads to increased respiratory work and caloric expenditure. That leads to reduced weight for age and BMI. And all these factors, they contribute to failure to thrive. So this is something, this reduced calorie intake and failure to thrive can be treated to some extent and should be taken into consideration while seeing a child with EOS. Also, they have obstructive lung disease. It occurs in approximately 1/3 of children with EOS. There is central airway narrowing. However, compression of the lower or mainstem bronchus can happen because of intruding spinal elements or mediastinal elements. So this obstruction could be because of the deformity of the spine itself. Lung function is affected, and this affection is asymmetrical. Typically, the lung on the concave side of the curve is affected more in majority of the patients. So why this is important? So it is important because the interventions on the side with greater function may predispose the child to respiratory failure post-operatively. So especially if thoracotomy is done on the concave side, then the possibility of child needing ventilatory support in post-operative period is high. Also, the children, they have poor respiratory muscle performance. The force generation involving both inspiration as well as expiration is less. This leads to rib crowding because of immobility. They develop ankylosis of the costovertebral joint. That leads to reduced intercostal muscle function. And because of this, they're more dependent on diaphragm for inspiratory work. How does it affect the child? Well, it causes increased risk of respiratory muscle fatigue and hypercarbic ventilatory failure. There are periods of hypercarbia during sleep and daytime hypercarbia at a later stage. Also, they are known to have sleep-related breathing disorders. They are studied to a lesser extent. There is prolongation and recurrence of hypopneic events during rapid eye movement sleep. Not necessarily everyone has this obstructive sleep apnea, but that prolongation and recurrence could be the part of a scale which is used to measure obstructive sleep apnea. It is not known whether sleep studies should be done in children and what is the best way to assess sleep-related breathing disorders in the children. It is still evolving. Pulmonary hypertension, although more common in adolescents with severe scoliosis, 10% of children with early onset may have pulmonary hypertension, and it will be typically seen in a child with severe spine and thoracic deformity. So in a nutshell, pathophysiology involves reduced lung volumes, reduced chest wall distensibility and excursion, and reduced respiratory muscle force and movements. So all this can lead to hypoxemia, poor sleep, increased work of breathing, tachypnea, respiratory failure, and ultimately cor pulmonale. So is there a correlation between physiological changes and structural features? Because as orthopedic surgeons, we may think so, but studies have shown that there is no correlation between the Cobb angle and thoracic dimensions and PFPs. So what does it mean that thoracic and spine structures may not be used as a surrogate marker for assessing the lung function? Pulmonologist consult is very important for direct measurement of lung function, although can be difficult in Indian settings. All the changes, they happen in children less than 5 years of age who are too young to perform various pulmonary function tests. So pulmonologist may consider other tests if possible. So knowing this pathophysiology, certain considerations need to be taken into account while evaluating a child. How severely the breathing is impaired at the first visit, the FVC is important. Are there any other pulmonary conditions which are impacting pulmonary function, such as recurrent aspiration syndromes, asthma, lung injury from previous infections? Certainly, one thing that needs to be considered is correction of malnutrition before posting them for any intervention, which certainly helps. So, in summary, pathophysiology should be taken into account during evaluation and treatment. Consider involving a pediatrician with pulmonology interest or pulmonologist from the beginning, and also consider optimization of reversible factors. Thank you. I thank Assi and Posi and BSI for this opportunity. Thank you very much.
Well, thank you, Ashish, for that very comprehensive coverage. I think you covered all important areas of, especially the cardiopulmonary physiology and pathology in early onset scoliosis. I think we'll have discussion, a common discussion at the end so that we can discuss all aspects of EOS. I would next invite Dr. Naresh. Dr. Naresh is going to speak to us on investigations, MRI, etc. in early onset scoliosis. So over to you, Naresh.
Thank you, sir. My slides up, sir. The slides visible, sir?
Very visible, yes. No issues.
Thank you very much for the opportunity to present the radiological and MRI evaluations. I think the setting has been set. We all now learned that how important it is to identify the factors. Unlike the adolescent idiopathic scoliosis, the US has got a specific radiological and MRI markers which needs to be clearly assessed for the progression of the disease and to assess the lung volumes and to identify where the pathology is and pick up the patients who are prone for worsening of the deformity. It comes in a huge spectrum. It can be like neurofibromatosis, very young age with formation defects, segmentation defects, syndromic patients. So every patient has got a different spectrum of disease and different presentation in the radiology itself. So radiograph becomes the first and primary investigation where we diagnose these patients, and this also forms a basis for how you follow these patients up. So because it involves a huge spectrum of the disease, it can be a idiopathic scoliosis in a juvenile or infantile scoliosis, or it can be congenital scoliosis. We need to pick up whether the patient has got any congenital problems of issues with the segmentation or formation defects, which have got different levels of progression based on the way they present in the radiographs. Neuromuscular patients behave all differently, and we need to pick up when you see the initial X-ray, the type of the curve, whether it is these long C curves, which are prone for worsening neurological deficits. And also the pelvic obliquity, which is very specific feature of this neuromuscular deformities. And all the syndromic patients, they will have different kinds of combinations in these patients. The standard radiographs, what we obtain in these patients are the upright AP and lateral scoliosis film series. But when it's when you have to deal with the patients who are very less than 2 years, it becomes very difficult to get a upright standing X-rays. You can have a supine X-rays to get knowledge about the pathology, but to know the progression and the flexibility are different presentations when the patient is walking. We can either have a seated radiograph. I think there are radiolucent chairs available. If you can't take a standing radiograph, either because of the age or because of neuromuscular or developmental issues, a radiolucent chair with the straps attached is a better option to investigate these patients for the progression. Unlike AAS, there are specific measurements. In AAS, the major measurements are the curve magnitude by COPS, and we assess the flexibility. Based on the flexibility and the curve magnitude, the treatment protocol will be decided. But in EOS, we need to know the specific features. We are more interested in thoracic length, the spinal length, the thoracic cage dimensions, and the lung volumes, and the predictors of progression. Either this child is going to worsen, and if it is going to worsen, how rapidly the patient is going to worsen. In infantile idiopathic scoliosis, there are some predictors which have been proposed by Vin Mehta by identifying the rib vertebral angle difference. One need to be aware of this rib vertebral angle difference because this forms the way the curve can be progressed, because few infantile idiopathic scoliosis patients can spontaneously resolve. Operating on these patients or subjecting these patients for growth rods is unnecessary, and it will be rewarded if you identify these patients who can be spontaneously correctable by correcting with the brace. So she has proposed rib vertebral angle difference, wherein we identify the angle between the vertebral body and the ribs on the concave and convex side, and the difference is the one which is going to matter. The 20 degrees is the correction, the factor which has been proposed. In addition to the rib vertebral angle difference, we can also, the progression can also be predicted by whether the spine or the rib is in the phase 1 or phase 2. What it really means in phase 1 or phase 2 is in phase 1, the convex side rib usually tends to be away from the vertebral body at the apex. If you see at the apex, if the rib is overlapping on the vertebral body, there is a high tendency for the progression of the disease. So this simple terminology or the concept combines the formation of the rib cage and also rotation of the apical segment. The apical vertebral body is meant to rotate, and the tendency for the rib head to overlap on the vertebral body. So there are studies done on the three-dimensional effects of this, what really means in the phase. When there is a phase 2, there is severe rotation, which is happening at the apex. So how do you identify these phases? We need to look at the apex of the curve and see how the ribs are being placed in relation to the vertebral body. If the ribs are overlapping, then you need to identify that this child is going to worsen, and we need a close monitoring and aggressive treatment philosophy. So how you basically measure this one is we need to use the placement of a small vertebral end plate line is usually drawn, and the longitudinal axis of the rib is done on the concave side and convex side, and you can use the SurgiMap software just to measure the angles and how much is the difference of the vertebral angle. Coming to the thoracic development, you usually tend to look at the spine and the curvature, how the spine is getting deformed in these patients. But it's also equally important how the lung volumes are can be seen on the X-ray, and this can also be used in the pre-operative and post-operatively, how much the lung capacity is increasing and how much this can change the lung function of the child after you apply a distraction device. The space available for the lung are being proposed to actually look at how much of the lung volumes are getting compromised because of the deformity. And this can be used as a serial prognostic indicator for the development of the lung. So how do you measure this space availability for the lung? The center point of the concave uppermost rib is taken under the diaphragmatic shadow. The center point of the diaphragmatic shadow are taken and they are connected, both on the concave side and convex side. And the volume is expressed as a percentage. Here, the concave side, it's 9 centimeters, and the convex side is 13 centimeters. And you calculate into the percentage, that is 69% is the actual the space available for the lung. And this can be used as a measure after correction of the deformity as well. So this, whenever you are faced with a child who is very young, and then you are, in addition to once you start measuring the COPS, once you apply growth rod, it becomes mere necessity to actually look into the other factors rather than the COB angle, because COB angle can be, it's fixed because you are already applied a growth rod. So the thoracic length on the concave side and convex side, and you identify the lung volumes, and the length of from T1 to T12, which measures the thoracic length, both in the AP view and also in the lateral view. Similarly, the length of the spine, which is usually measured from the T1 superior end plate to S1, T1 to S1 length, both on the AP and lateral radiographs, is the one which is going to give the overall spinal length. And also the width of the thoracic cage can be measured from the AP X-ray, and the depth of the thoracic cage can be measured from the lateral X-ray. These are the main parameters which we need to be aware of, in addition to flexibility of the curve and also the COB angle. So flexibility are usually measured by either supine side bending views or lateral side bending views and the traction views. This is very important before we apply for the growth rods, because once we apply the growth rod in these patients, we can't measure the flexibility any further. So this becomes important factor when you are trying to do the final fusion. We don't know how much of the curve correction we're going to get. Once you know before the application, the flexibility of the curve that can be compromised. So other most important factor in these patients with other spectrum of disease, which can be picked up on X-rays, and which we need to be very careful in following these patients, are the congenital EOS patients due to formation or segmentation defects. This can happen in different forms. Whether you can have a hemivertebra, or we can have absence of pedicles on one side, and can have a block on the one side, and is a combination which is very highly notorious for progression. Bar on one side and hemivertebra on the other side. Whether the hemivertebra has got the growth potential left over or not, whether it's fused hemivertebra or incarcerated, are the ones which we need to be aware of and also look for them in the X-rays. So you can see there can be a formation defect here, and there can be a intact growth plate on the above and below, and this can be incarcerated on the one side, and it can be free on the other side. And you need to be aware of the bars which happen, and these bars are notorious for progression. When this bar is associated with the unsegmented bar associated with the hemi on the other side, they can rapidly progress. And also the rib formation defects, or the absence of ribs and the fusion of the ribs, which will have an effect on the lung function of the patients, can be picked up on the initial X-rays. So this is a different way of classifying these patients with either the hemivertebra is semi-segmented or fully segmented. Fully segmented have a growth potential double that of the semi-segmented. If it is incarcerated, the chance of growth is a little less compared to the other ones. The block vertebrae, usually they don't tend to progress because there is growth plates, or the curve is not going to tend to progress, but the height of the cage may be affected. But the unsegmented bars are the ones which are notorious for progression. So if you see this patient which presented like this, we need to be very careful of what exactly is having the patient is having on the initial X-rays. You see the top two are the unsegmented bar at T10 and T11, and also T11, T12. These have high risk of progression. But there is a fused vertebra at L34, which has very less chance of progression. So these things has to be addressed and then identified in the initial X-rays. But it is very easy to look at these patients and identify the defects in the radiographs of the patients who are less than 4 years. Once the child matures and ages after 4 years, becomes a little difficult to identify exactly where is the bar and how is the bar, and whether there is a growth plate left over. So these cases, in these situations, when you are planning for surgery, it becomes mandatory to get a CT scan to identify the growth potential, or MRI to identify the growth plates left over for the growth potential. The CT can give you exactly the delineation of how the growth plates are still remaining and what needs to be addressed and where exactly it needs to be addressed. When you faced with the long C curves like this, neuromuscular scoliosis and thoracolumbar deformities, the treatment philosophies altogether changes, and we need to be careful in following up these patients and identify the pelvic obliquity, which is quite common in these patients, which needs to be corrected. So coming to the next part of the presentation, in addition to the radiographs, it's very important to identify what exactly is inside the spinal canal. Unlike AAS patients, the EOS patients has got high chance of intraspinal anomalies that it can range from 18.3% to 47%. It becomes mandatory to get an MRI before we are operating on these patients, and also to need to note the growth potential of the disease. Syringomyelia are the commonest problems which are usually associated. In addition to that, Theater-Pard syndrome is the one which is very important, which we need to pick up. Otherwise, applying a growth rod or correcting these patients and lengthening the spine can be a problem. There are some cutaneous markers which will give us an idea of what exactly is going to be in the spine. And also, if you face with the patient who has got some neurocutaneous markers and also a congenital defect in the formation or segmentation, it becomes highly mandatory for getting these MRIs. And this patient has got a tethering, and there is a it's high risk if you don't release these patients and subject these patients for the surgical purpose. Split cord malformations are the second most common problems in these patients. It can be two types. It can be type 1, type 2. In type 1, what we usually call as a diastematomyelia. Cord is split into two. There is a cartilaginous spectrum on the each side. And type 2 is the one is split by fibrous septum with wide canal, two dural sleeves, also known as a diplomyelia. And these patients also present with the deformities of the foot, and we need to be very careful in identifying and, if necessary, releasing them and addressing these deformities before surgical procedure. Neural ectasia is quite common associated with neurofibromatosis, Marfan's Ehlers-Danlos, and achondroplasia. Sometimes it can be idiopathic as well. It presents with the widening of the dural sac and associated with NF1, and it outpoaches through the enlarged neuroforamina, erosion of the bone. This becomes a lot of problems, causing the erosion of the vertebral bodies and scalloping and pedicle erosions and foraminal enlargement, sometimes leading to kyphosis. It's important because it erodes the vertebral body and leads to very angular kind of deformities involving few segments. And vertebral fractures are quite common, and neurological deficits are also a problem. And it's also important to get a fixation points in these patients. When you have a wide canal, it becomes very difficult to put a vertebral pedicle screws. You may sometimes need to depend on the sublaminar wires or different philosophies of fixation in these patients. In summary, in addition to curve magnitude and flexibility, we need to look at the other factors like thoracic spinal length, thoracic cage dimensions, lung volumes, and predictors of progression in various kind of pathologies. And MRI is mandatory to rule out intraspinal anomalies. And CT will help providing finer details in these patients. Thank you very much.
Thank you very much, Naresh. I think, again, a very comprehensive coverage of the radiological modalities and MRI and spinal dysraphism in early onset scoliosis. I would next call upon Shyam. Shyam is going to speak to us. We are starting with interventions now, and Shyam is going to speak to us on one of the very important intervention in early onset scoliosis, which is casting. So what are the indications for casting and what are the techniques? Over to you, Shyam.
Good morning, everybody. Can you all hear me?
Yes, can.
Yeah. I'd first like to thank all of you for this opportunity. I am incredibly honored to be here to talk to you all. I have teachers that I respect and have known for a long time, and colleagues and friends. So what I'm going to talk to you about today is what I've learned from my experiences in casting kids. So the data that's there, that's presented in this paper or in this presentation, is from a prospective study that was published a couple of years ago. I have no disclosures. So the goals of treatment of early onset scoliosis or thoracic insufficiency, I club them both together because they are intricately related, are due to the 3D thoracic deformities. So what would we like to do? We want to increase the thoracic volume to prevent or correct the restriction. We'd like to obtain symmetry of the thorax. We'd like to derotate the spine because there is a fairly significant impact of the rotational deformity on the tautness or the tightness of the diaphragm. So you can imagine if T12 and L1 are rotated, they kind of spin the diaphragm and tighten that and decrease the diaphragmatic excursions. Hence the importance of derotating the spine. To improve thoracic function and its mechanics, to try and equilibrate the thorax by lengthening the concave constricted hemithorax and improve the abnormal side, and to maintain these improvements during growth. And the purpose of all of this is to try and give the lungs the space available to develop the alveoli. Ashish very beautifully showed how the lungs develop in the growing child. Now, we want to also avoid growth inhibition procedures for these children, and we want to avoid iatrogenic shortening of the spine and thoracic fusions. So it brings us to the treatment options here. So you have non-operative treatment options and operative options, the non-operative ones being bracing, which is not very effective in this patient population, and casting, which I'm going to talk about a little bit. The type of casting we use is the EDF, or the elongation, derotation, flexion casting. Operative treatments include non-fusion surgeries that are distraction-based or guided growth-based. The distraction-based ones include the growing rods, which are rib-based, based on where the foundations are, or spine to rib. The guided growth options include the Schiller technique, which is from Little Rock, where Ashish was on faculty for some time, or the vertebral body tethering, or posterior tethers, as the case may indicate. The other operative procedure is a fusion, which we want to try and avoid in the very young children. There are many complications associated with even the growth-friendly and fusion-less approaches. So I am here to propose casting or serial casting as a complementary or alternative method of treatment for scoliosis. Casting was first done by Joseph Risser, which is the traditional casting, and it uses a 3-point bend for correction. It was not until Morel and Cottrell in 1964 described EDF casting to address the rotational aspect of the deformity. And this was popularized by Min Mehta, who we all know. Now, like I said earlier, this is all data that was done from work done that was done when I was at Riley Children's Hospital, and this was prospectively collected. So we have 50 children aged 6 months to 10 years with early onset scoliosis that were treated with casting. All the casting was done under general endotracheal anesthesia. We had a total of about 175 casts. We measured a lot of things during this study. I measured pulmonary compliance, tidal volumes, airway resistance, peak inspiratory pressures. Now, the impetus for this is actually because Dhawale had done a very nice study before that, showing that casting increased peak inspiratory pressures during the procedure. I used the Philips module and an airflow sensor, and the measurements were obtained before and after cast removal, before and after spine traction was applied, after cast application, and out of traction after the cast windows had been removed. So I measured the amount of traction that I was applying for all of these patients. I had a small inline a scale that was used to measure the amount of traction, and I measured it at the beginning of application, at the beginning of casting, and at the end of casting. A few things that I'd say are really important for those that get started on casting. Endotracheal intubation is important. You have to use a bite block, otherwise the traction will have them pinch the endotracheal tube and you will not be able to ventilate your patient. You will place abdominal pads under here, and that is important for after the cast is applied, because as soon as the patient is off the traction table, that padding will be removed, allowing for room in the belly to allow ventilation. And be aware and expect respiratory changes during this procedure. If your anesthesiologist is not used to this, they may be very alarmed at the numbers that their monitors may show them. This is the frame that I use. It's marketed in the United States as a Noel casting frame. Now, based on this, actually, the engineers at Ashish's hospital made a frame for us to use, which we used afterwards. It's just a very simple system of, traction belts and ratcheted levers, which allow you to apply traction to the patient. This is sort of where the position of the patient is. There are two horizontal bars here, one by the pelvis and one under the shoulders. The traction is applied through a head halter. Notice the endotracheal tube in place. The legs are suspended with a sling, and the traction on the pelvic side is applied through pelvic slings. These are the pelvic slings that I use. I use a t-shirt, which we place on the t-shirt on the patient first, and this is just regular stockinette that's applied. We tie the stockinette, a 2-inch stockinette, around the waist, fairly snug, and then a second knot a little distal to that, which allows for the attachment of the traction belt. Now here we are transferring the patient onto the traction frame, and that is the patient suspended on the frame. So a halter is there. I've made a little cut in the neck on the mandibular side to allow the mandible to sit there in place. This actually also helps hold this part of the halter in place and prevents it from going back. When I first started, I didn't do this, and the halter would sometimes go back and apply an external pressure on the airways and the carotids, which is not a very pleasant thing. I also place a little covering on the head, and this comes into use later on when the windows of the cast are cut. You see the slings that are there on the pelvis. The patient is suspended between these two parts, and there's the padding to allow room for the belly. You can practice the derotation maneuver before applying the cast. So here, this patient has a right thoracic curve, and my left hand is here to pull the chest up on that left side. This is after the cotton is applied. And here we go. This is the patient after the cotton has been placed over the stockinette. Here's the pelvic foundation. So I typically apply the cast in stages. I apply a nice foundation around the pelvis, and then a nice foundation at the top. And then we complete the middle section of the cast. As the cast is curing, we start doing the derotation maneuver. Remember that the traction is used to elongate the spine. The flexion is the gravity that allows the spine to sag. And then now the derotation maneuver is applied. It's typically 3 sets of hands. So you have the surgeon or the applier of the cast doing the procedure. You have a second person proximally applying a derotation motion to the chest or the shoulders, and a third person distally kind of applying a derotation to the pelvis to counter the motion that the surgeon is doing. And this illustrates the derotation maneuver. This is what separates this from the original Risser type casting, where it was just a fulcrum bend. Here we are doing the derotation of the cast. The frame has a mirror that allows you to look to see how you are placing your hand for the derotation. and that is the cast being completed. I like to put a firm mold over the symphysis, and then I would typically get an in-cast X-ray when I was doing the study to see how much of correction was obtained in the cast. And then we mark out the windows to be taken out. You'll notice that the windows are very large and generous. So in this kid who had a right thoracic curve, we pushed down on the left anterior hemithorax, but I want the right hemithorax to come up. So I have cut the cast off from the meridian on the right side, allowing the entire right hemithorax up to derotate the spine. Similarly, we have large posterior windows, and these windows allow the unsupported left side of the chest to rotate out. Here we are completing the petaling of the cast, and that's what the finished product on that particular patient looked like. I use simple tape, and I often offer the patients the choice what design they want, and I would have these sorts of designs on my patients' casts. It made it a little more acceptable to the young kids. So the key were to cut large windows. I would take out any part of the cast that did not need to be there to exert pressure on the child. The windows gave plenty of room for the chest and the body to rotate out. It gave room for the stomach, so the kid would tolerate their feeds. It gave room for the lungs, and this allowed easy skin care as well. So when Dubusse first saw pictures of my casts, he remarked that these looked like French windows, large windows that you could walk out of. So our observations in the study were that pulmonary compliance, tidal volume, airway resistance, and peak inspiratory pressures showed improvement as we went through, or stabilization. And that the maximal decreases in all of these. So tidal volume and compliance decreased as you applied the cast, and airway resistance and PIPs increased. But as you continued following these kids, those changes were not as severe as they were in the first cast. I'm going to show you some illustrations of 100% cast correction, curve correction now. This is a patient who in 3 casts went from 43 degrees to under 10 degrees. Notice the amount of derotation. The pedicles are symmetric now on this. The chest is symmetric. The space available for the lung is good. The curve is not very large though. It's only 43 degrees. Here is another example of a kid with 45-degree curve with 2 casts down to under 10 degrees. You can see the shadows of my cast showing that how much is open for the chest to derotate. Now, kids who had greater than 75% correction, this is an example of a patient who went from 75 degrees to 26 degrees in 4 casts. Another one that went from 72 degrees to 25 degrees in 10 casts. This kid was a kid who unfortunately came to us fairly late. There were issues with insurance and so on, and social situation that didn't allow us to get to her early enough. Curves with less than 75% correction. Here's a kid with 83-degree curve that went down to 29 degrees in 6 casts. And another one who had a 110-degree curve that went down to about 41 degrees after 5 casts. So what are the indications? Now, I was to talk on the indications and the actual technique. So after all these years of doing this, my indications are very simple. Any child with a progressive spinal deformity that can tolerate a cast and needs time before surgery can be done is a candidate for casting. But you also need to know what possible behaviors of the curve may be to set the expectations for your parents and yourselves. Thank you very much. I have a few more slides if there is time that I can present, but we can discuss all these things. I have shared the entire presentation with everybody, so feel free to use all of it. Thank you again.
Well, thank you, Shyam. Again, a very nice presentation, and you've been speaking from your own experience, I think, which is quite vast. You know, you've done so many cases. So that was a very nice talk, and Dr. Salil is here now, and he is going to be speaking to us on growing rods. So you've been introduced already. please go ahead with your topic, Salil.
Yes. Thank you so much. Thank you for this opportunity to present. You're able to see my slides there. Great. All right, excellent. So I'm going to be speaking about growing rods. Again, I've been asked to speak about when, the indications for these procedures, and how I do it. These are my disclosures. None are relevant to this talk. I think we've covered these foundational slides very nicely. So the surgical interventions in early onset are ultimately to allow us to increase thoracic height, somehow influence thoracic volume. So Ashish gave us a great introduction showing that increasing height doesn't necessarily always improve the function of the lungs. So we're there to facilitate lung development and hopefully to alter the natural history. So these children definitely have an increased mortality rate, and hopefully we can change that by the interventions that we're taking on. So the indications of when to intervene with surgery, I completely agree with Shyam. I think casting should be always option number 1, 2, and 3 for these patients. You want to delay surgery for as long as possible, but obviously by the time you get to needing to do surgery, you want to make sure that there is growth potential. So ideally, I like to wait until the child is at least 6 before we start with surgical interventions. And then if they get to 8 to 10, that's where I start to think about a definitive fusion. So that ultimate age for a definitive fusion is, I think, slowly creeping down. And as the longer term studies with growing rods, with MAGIC, as well as with Vector, have shown that increasing the T1 to T12 height doesn't necessarily do any favors for the child if we're increasing the stiffness of the chest wall. And then in terms of curve magnitude and stiffness, again, I try to delay surgery for as long as possible, even if we have a 60, 70 degree curve. If it's flexible with my push prone views or traction views in clinic, I try to talk them into delaying further with either casting or bracing. And so you want to have documented curve progression despite the non-operative options. So Shyam touched on these a little bit. They're, quote unquote, growth-friendly strategies. Ultimately, we're just trying to match the expected increase in height of the spine as the child is going through these early growth spurts. So there's growth guidance techniques, compression-based techniques, as well as distraction-based. This talk is primarily going to focus on the distraction-based techniques, but I just wanted to show a few photos of the Shilla technique that Shyam mentioned. Here, we're trying to do an apical fusion with extra long rods at the top and bottom of the spine to allow the spine to continue to grow. And then a modification of that Shilla is to use active apex compression, so on the convexity of the curve, to compress the spine to get some deformity correction at the apex, but then again, allowing the spine to grow, guiding the spine's growth over time. These compression-based techniques, I honestly wouldn't even mention in a talk for early onset. Obviously, there's a lot of popularity for the vertebral body tether now in idiopathic scoliosis, mostly for juveniles and very young adolescents. I don't really think that's a great indication, especially for congenital scoliosis or any of the other etiologies for really young children, so 5 to 10-year-olds. You don't want to start getting involved in staples or tether because of the high risk of failure and the need for revision surgeries. So I think the gold standard here is still distraction-based techniques. I'm going to talk about both traditional growing rods as well as magnetically controlled growing rods. I think Vector is really designated primarily for thoracic insufficiency syndrome. So if you have some significant congenital rib anomalies, large portions of the chest wall that are fused, that's where I think you can use Vector to separate the ribs and keep the ribs distracted to allow indirect control of how the spine is deforming. And then there's some newer growing rod alternatives that I just wanted to touch base on. I don't think they're available in the markets, even in the US, but there are some newer strategies to try to get the spine to grow as the child is growing. So the traditional growing rods were first performed by Paul Harrington in the 70s. I guess you could consider the Harrington rod as a growing rod. It had hooks at the top and bottom with a single distraction rod posteriorly. And then Mo et al. Modified his original description, his original techniques in the 80s, allowing for multiple level attachments, again, at the cephalad and caudal extent of the spine. But all of these were single rod techniques, and I think a lot of studies recently have shown higher risks of complications with single rods, including implant failures and crankshaft. So the dual rod techniques popularized by Akbarnia in the 2000s has really become the gold standard, at least here in San Diego. I'd love to hear about your experiences at your institutions. So this is how I perform traditional growing rods. Ultimately, you want to choose an upper and lower instrumented vertebra that's in zone 1. So it's kind of centered over the center sacral vertical line. And I'll show some cases when obviously there's significant deformity in the spine or translation of the chest along over the pelvis. So you have to modify these rules. Ultimately, you want to instrument either 2 or 3 levels at the cephalad and caudad extent. Typically, I like to perform that with 2 separate incisions as shown in the lower image, with a subperiosteal dissection only for the anchor points. With larger deformities, with an S-shaped deformity, I tend to open up the entire spine, so using a long incision, but obviously keeping the fascia intact in between the subperiosteal dissections and still passing the implants, the rods, underneath the fascia to decrease the risks of wound infection. For my proximal foundation, I typically like this hook-claw construct with a cross-link, so an downgoing and upgoing laminar hooks, and the crosslinks adds additional stability to kind of connect the 2 rods. Pedicle screws are commonly used as well. Obviously, there's the risk of posterior distraction of those screws could potentially damage the spinal cord as they're pulled out. But I'd say if I could get a pedicle screw in comfortably based on the patient's anatomy, I would prefer pedicle screws even in the proximal extent. In the distal foundation, definitely lumbar pedicle screws, and there typically 2 levels is more than enough. And then you're passing the rods subfascially. With the traditional growing rods, typically we use these inline connectors and leave them closer to the distal extent of the wound to allow for incisions distally to distract the rods further. And then the goal is to limit exposure, because ultimately any part of the spine that you expose is going to get an autofusion, making the final instrumentation and fusion more complicated. So the outcomes of traditional growing rods have been published. Obviously, there's able to control the magnitude of the deformity, maintain spinal growth to nearly matching the growth of the thoracic and the lumbar spine. Everyone is very familiar with the law of diminishing returns. Usually after about 6 lengthenings, there's significant fusion that's occurred. And even with traditional growing rods, you're less able to distract. And there's overall about a 50% complication rate published. Shea Bess's classic article kind of breaks down the number of complications that can occur with traditional growing rods, including implant failures, skin breakdowns, infections requiring multiple revision procedures, as well as anchor failures, both at the proximal and distal extent. My preference is to stick with spine instrumentation. I try to avoid rib instrumentation as much as possible, just because of the higher risk of anchor failures that happen with rib fixation. So the magnetic growing rods were introduced in the US in November 2009. I was fortunate to be a trainee under Professor Akbarnia when he performed his first surgery at Rades. And then the outcomes were published in 2012 and 2013. So this was the first patient that was performed. I'll show some images from him on the next image. Overall, the magic growing rod correction rates have been found to be similar to traditional growing rods. And overall, there's a higher upfront cost, which tends to be balanced by about 4 to 6 surgeries that don't need to be performed, because obviously these lengthenings are performed in our clinics. And overall, there's still a high rate of implant failures and unplanned returns to the operating room with both of these techniques, traditional as well as magnetic growing rods. So this was this first patient that was performed. He was an 8 plus 11-year-old boy with an idiopathic early onset scoliosis, a significant curve of more than 100 degrees that had excellent initial correction. That correction was actually maintained. He needed to just have one revision for implant failure and then went on to his final fusion. So with magnetic growing rods, there are some absolute contraindications that everyone should be aware of. So you want to avoid these rods with infectious or pathologic conditions that might weaken the bone. If the patient has any metal allergies or sensitivities, or if they have implanted pacemakers or other electronic devices that would interfere with this external magnet that's applied to their backs in clinic. And also this younger than 2 years and less than 25 pounds has become more of a relative indication, I think, as people have used these rods in some extreme situations. But despite this newer technology, there's still newer failure rates. So obviously you're familiar with modulosis being a significant concern. There's a lot of debris that's generated with these titanium implants, and most of that debris seems to come from the rods rubbing against each other. And then some of the newer generations of the magnetic rods have had this failure of the actuator pin, where the Magic X device was actually taken off of the market for a number of years before now we're finally able to use it again. So just because there's a new technology doesn't mean that it's solving any of the issues that we've had with traditional growing rods. And then I'd say these are my indications for still using traditional growing rods in the age of magic. So this is one of my patients with Prader-Willi, significant obesity. Typically when the thickness of his back goes more than 5 centimeters, the external magnet has a lot of difficulty activating the magnet within the rod. If there's a small stature, again, as this patient had, the actuators are only 70 to 90 millimeters in length. And as you can see, ideally you want those to be just in the thoracolumbar junction. It ended up taking up his entire thoracic spine. If you have significant kyphosis, if they need frequent MRIs, or if their distractions have been maxed out with the power that the magnetic rod can generate, oftentimes you need to go back to traditional growing rods. And then finally, a quick word about these patient-reported outcomes. This is a study published by Mike Vitale in 2011. I think, again, like Ashish mentioned, I think the EOS quality of life questionnaires, as well as the pulmonary function tests, are the most important outcome measures that we should be using in early onset scoliosis. The length of the spine, this artificial, 20 centimeters space available for the lung, all of that doesn't really lead or result in improved outcomes for the patient. Ultimately, you want to make sure that you're treating their psychological burden as well as their pulmonary function, and those are going to be the ultimate outcomes that matter. So here's a quick case example. Here's an 8-year-old female with syndromic scoliosis. Triradic cartilage is open. She's Risser 0. I've been managing her since she was 3. She's had a series of casts with breaks, using bracing in the intervals. I'd love to hear from Shyam in terms of his routine for when he alternates between casts and braces. So ultimately, she was getting skin ulcers with her casting, and so it was time to proceed with surgical treatment. As you can see, her UIV and LIV would be in different zip codes. So I decided to stage her procedure. We did an initial exposure with instrumentation and small rods to get fusions at the UIV and LIV, and then applied halo gravity traction to keep her in the hospital for a 6-week period to slowly increase the amount of weight applied to her spine. So this is the image on the right is where we got her after her period of traction, and then magnetic growing rods were applied at about 2 months from her initial surgery. And here she is 3 years post-op. You can see the amount of distraction that she's achieved. This has all been accomplished with 1 surgery. She's 11 now. Her rods have maxed out, but I'm just going to continue to observe her until doing a definitive fusion down the road in the next year or 2. So a strategy to minimize complications in these challenging populations. So some of these growing rod alternatives that are being explored, there's this one-way self-expanding rod that you can see is pictured here that has a ratcheting device that slowly continues to expand. You can see that it's still a dual rod technique, so pretty similar to Harrington's original description, but using the dual rod stabilization to improve outcomes. Again, there's very few case reports published with both of these devices. And then the second one is the spring distraction system. You can see the device on the right side. Again, similar principles, but using a spring to slowly continue to lengthen the spine to drive the spinal growth instead of just allowing the spine to grow and supporting the growth. So some take-home points. Ultimately, you want to delay surgical intervention for as long as possible. You want to optimize deformity correction at the index surgery, because I think that's about as straight as you're going to get the patient over time. You want to understand the limits of the MAGIC technology and know when you still need to use traditional growing rods. And ultimately, the most important outcomes in these patients are going to be their pulmonary function tests and their patient-reported outcome measures. Thank you again.
Thank you. Thank you, Salil. Beautiful coverage. We move on now. And Ajoy is going to speak to us on hemivertebrectomy and fusions.
Thank you, sir. At the outset, my thanks to ASSI and Posi for the opportunity. I'm going to speak on hemivertebrectomy, why, when, and how. Hemivertebra is a spectrum of disorders. I mean, basically, depending on the location of the hemivertebra, we may get a kyphosis, a scoliosis, or a kyphoscoliosis. For me, one of the most important hemivertebra is a posterior quadrant hemivertebra because it causes kyphosis, which leads to a higher chances of development of a neurological deficit. Therefore, why we should resect a hemivertebra? Because hemivertebra, like a normal vertebra, has got a significant growth potential. The growth potential varies depending upon the type of hemivertebra, but as you can see in this image, a hemivertebra which has gradually progressed to develop a significant kyphoscoliotic deformity. It's also important to resect a hemivertebra because with growth and with time, it leads to an asymmetric effect or loads on the adjacent vertebra, leading to secondary curves, which are initially flexible and later they become structural. As you can see in this child, the primary curve is relatively very small, whereas the secondary curve, which has become structural, is the one which has caused significant cosmetic deformity to the child. Therefore, it's important for us to identify a hemivertebra much earlier and to do the necessary intervention whenever it is necessary. What are the factors affecting the progression? The type of the anomaly, the site of the anomaly, the number of malformation, as mentioned by Naresh, the associated other anomalies like unsegmented bar or hemis on the same site. We all know the classification of hemivertebra, and we know that the fully segmented hemivertebra is the one which is most likely to progress as against a non-segmented hemivertebra, which has got a less chances of progression. The site of anomaly, as shown by Dr. McMaster, we do know that the thoracolumbar or a lumbosacral hemivertebra are more likely to progress, and they are more likely to cause cosmetic problem in the form of a neck and shoulder imbalance, higher chances of progression, and a pelvic and a truncal imbalance. Therefore, it's important for us to identify the type of hemivertebra and the site of the anomaly and its associated other anomalies, which will have a significant impact on the type of progression that particular curve is going to have. One more example of a lumbosacral hemivertebra where there is an oblique takeoff of the lumbar spine, and initially there could be a compensation, but this leads to usually a significant lumbar rotation and also a pelvic obliquity. And as you can see in this particular example, the deformity tends to become more severe, rigid, and causes significant impact on the overall function of the particular patient. Coming to the next question as to when to operate. as we mentioned earlier, it's important to recognize curves which are likely to progress based on the natural history and by understanding the McMaster chart. We always prefer nowadays to identify them very early. Once we have identified and looked at the natural history of that particular type of anomaly, documented progression, it's better to treat them very early so that the chances of the curve becoming significantly more is avoided. If you wait for a longer duration of time, like in this adult person with a neglected kyphoscoliotic deformity, the amount or the magnitude of the surgery which we need to do becomes significantly more, with more complications and higher risk. It's not necessary to wait for a longer duration of time to document progression. The moment we realize that the curve is progressing with serial radiographs, it's important to intervene at that particular time rather than wait for the curve to become much more significantly bigger or structural. The advantage of this is that we can do a relatively simple surgery and it is a short segment fixation, which gives overall good results rather than wait when the secondary curves become structural and we need to do a prolonged or a long duration of surgery. When to operate, the goal is to have a straight spine with normal physiological profile and a short fusion. Therefore, we should operate before the adjacent vertebra develop asymmetrical shape or before the secondary curves become structural. Therefore, what is the ideal age? It usually in a solitary hemivertebra, the ideal age is between 2 to 5 years, so that we wait for adequate development of the bone, better ossification, but the curve is still flexible, and there's adequate soft tissue to cover the implant which we are going to introduce when you are doing the deformity correction. As I mentioned earlier, a delayed surgery usually includes a secondary vertebra and the compensatory curve. How we need to plan the excision? As Dr. Naresh has showed, we have to go through the radiographs to identify the type of anomaly, the level of anomaly, what is the sagittal and coronal alignment, the associated abnormality that has to be looked at. CT gives us a better idea about the position of the vertebra, associated lamina. Sometimes the lamina could be deficient, but most of the time there is a half development of the lamina. If there is a deficiency, then we should be more careful while we are doing the exposure. The status are the shape or the size of the pedicles and the associated abnormalities. We all know that congenital anomalies are associated with neuraxial abnormalities. Therefore, it's always important to get an MRI done before we proceed on to do the surgical intervention. Coming to how to operate, the factors to be considered is the length of the incision. As mentioned earlier, immature spine fuses with the exposure. Therefore, it's important to limit our incision to the levels planned for the fusion. Dissection is also important. Prevent the PJK by preserving the midline structures whenever it is possible. Try not to damage the capsule at the upper extent so that to prevent the chances of PJK. Pedicle screw fixation. It usually is the mainstay when you do a hemivertebra excision. It should be preferably an image guided. Relatively, because the bones are relatively weak, the biggest diameter screws, the longest diameter screws should be the one which we should try to introduce. If it's necessary, if the quality of the bone is not good, it may be better to reinforce the fixation by using hooks or an additional hook rod construct as shown in the figure on the right. In thoracic, it's relatively easier to excise the ribhead and the nerve roots, whereas in the lumbar, it's always important that the nerve roots should be identified and spared. The careful exposure of the hemivertebra and the posterior elements is important. Periosteum to be preserved outside the area of the fusion. We should always remember that most of the hemivertebra, especially in the thoracic or the thoracolumbar area, are situated on the posterior side, and they're more likely to cause kyphosis. Whereas the lumbar hemivertebras and the lumbosacral hemivertebras are usually in line with the coronal plane. Therefore, your dissection tends to be more into the lordotic segment or more anteriorly, whereas the thoracolumbar hemivertebra is easier to approach. The spinous process lamina and the facet joints are removed. There are 4 biological principles as put by Bologna et al. The option 1 is just to resect the hemivertebra, wherein you retain the surrounding growing structures and use compressive forces to close the gap. And there is a spontaneous filling up with new bone formation. Whereas option 2, along with the hemivertebra, you remove the part of the growing structures. Whereas option 3 is what I personally usually do most of the time, is excising the hemivertebra and the surrounding growing structures along with the adjacent part of the disc. And this gap, usually we apply a compression force. If the gap is bigger, then you can fill it with bone graft or a cage. And this is what I usually do apply. And very rarely you have to do option 4, that is complete excision, something like a vertebrectomy, which is probably necessary when you delay the procedure when the child is relatively older, where you need to excise it like a total vertebrectomy. Therefore, how to operate? The transverse process and the rib head needs to be resected in the thoracic spine. The pedicle excised as needed. The anterior and lateral aspect of the hemivertebra are excised. As I mentioned, in the thoracolumbar area, the hemivertebra is the one which we usually approach first at the apex when you do your dissection. You first identify it, identify the lateral aspect, remove the transverse process, and in the rib in the thoracic spine, get to the lateral margin along the lateral aspect of the body, further as much anteriorly as possible. Then you excise the lamina so that you identify the whole of the pedicle. And this involves when you totally denude the pedicle outside, and then you can excise the disc leading on to complete resection of the hemivertebra. The compression is applied on the convex side until the gap closes. You should always remember to look at the CT scan. If there is a concave bar on the opposite side, it needs to be osteotomized. These are some examples of hemivertebra where there is no structural changes in the adjacent vertebra, wherein it was excised and stabilized. Sometimes when the quality of the bone is relatively poor, your purchase of your screw is less, it can be augmented by using hooks construct and the supralaminar and the infralaminar hook, which can also be used to close the gap so that the stress on the pedicle screw bone interface is relatively lesser. This is an example of a child with a Treacher-Collins syndrome at a 7-year follow-up, reasonably well-maintained correction. What about using a unilateral approach? But my preference is always a bilateral approach, because to close once you excise the hemivertebra, and if you want to close it, you need to mobilize the disc space on the opposite side. And for me, that's why I always prefer to do this type of approach. What I usually do is to go on I put the screws and then go on the concave side, excise the facet, mobilize the disc space. And then once I have done that, put a temporary rod on the concave side, then move on to the lateral on the convex side, do the hemivertebra excision. And that allows you to compress so that your primary aim is at the end of your excision, the end plates are parallel to each other. And that is really important. As you can see in this example, the end plates are not that much parallel. And I'll show you later why trying to get a good parallel end plate is important, so that it prevents the adding on, so that the deformity is corrected and the chances of adding on, which happens later on, becomes significantly less. These are few case examples. I'll show you a case example of a posterior hemivertebra wherein it was a relatively older child, about 10 to 12 years of age. We just did the posterior instrumented deformity correction and fusion. And over a period of time, as you can see, over a period of 4 years, how the anterior part of the vertebra has grown. The basic problem in these type of scenario is because the facet is subluxating, it is causing a pressure over the anterior part of the vertebral body, preventing further growth. Therefore, once you correct the deformity, stabilize it and fuse it posteriorly, the anterior part of the vertebral body starts to grow again. I would like to just show a short video of a 3-year-old child with a deformity of the back, which has been progressively progressed over a period of 2 years. In spite of serial casts and braces, the deformity tends to progress to about 86 degrees. The child had two hemivertebras, a T12 and L2 hemivertebra. Therefore, since the deformity was progressive with failure of the casting method, but still it was flexible, it was planned for excision of both the hemivertebras. As I mentioned earlier, my first stop is always to put the screws and then mobilize the disc space on the concave side. Then only go to the opposite side to identify, enucleate, remove the lamina so that you identify the pedicle. This is, in this case, this is the pedicle of the T12 vertebra. You identify the pedicle, you remove the lamina and totally deskeletonize it so that you can protect the nerve root before we start doing the excision of the hemivertebra. As you can see, this is just a laminectomy. You can do a laminectomy using Kerisons, nibblers, or even nowadays by using an ultrasonic bone cutter. The advantage, as I mentioned, most of them are situated on the dorsal side. Therefore, the dura is away from the excised part of the hemivertebra. This is using an ultrasonic cutter to perform the remaining part of the laminectomy. And once you have removed the facet, removed the lamina, next step is to mobilize or do the discectomy above and below the hemivertebra. And once you have released the disc above and below, it's usually quite easier for you to totally enucleate the whole of the hemivertebra. I'm sorry, it's a bit of a magnified view under the microscope. The whole of the hemivertebra is now mobilized and excised. It's important to remember that it's always important that you have excised the end plate of the vertebra above and the vertebra below, the cartilaginous end plate, so that you'll be able to close the defect and also achieve good fusion. In this patient, since there was two hemivertebra, we went on to excise both the hemivertebras. A rod is placed then on the convex side. The other rod is still intact but is released and the deformity is corrected. Depending upon whether it is a significant kyphosis, we prefer to place a cage inside. If not, pack it with a lot of bone grafts, compress it to achieve a good correction. It's important to follow up these children on a long-term basis. As I mentioned earlier, it's important to get two parallel end plates. And as you can see, compared to the first year and fourth year, at the end of 8-year follow-up, you can see there is an adding on. There is some degree of kyphosis. The child is now about 20 years, is now 20 years of age, but the deformity is acceptable. But a long-term follow-up is very, very essential in these pediatric or early onset scoliosis children. To conclude, hemivertebra excision to be considered when there is evidence of progression. The ideal age is between 2 to 5 years or before the adjacent vertebra develop structural changes. Aim is to have the shortest segment fusion with parallel end plates. Sometimes it means that you may have to include 4 vertebrae, or usually whenever it's very earlier, the quality of the bone is better, it may be a very short segment. I would always prefer to mobilize and excise the disc on the concave side to achieve easy correction and reduce the stress of the implants before I go on to the convex side. And it's always important to have regular follow-up, even after skeletal maturity, or up to skeletal maturity is definitely very often, but even after skeletal maturity, to know whether there is an adding on or the deformity is progressive. Thank you very much.
Well, thank you, Ajoy. This is very beautifully explained and illustrated in your lecture. Your lecture was an excellent one. We are running short of time, and we have 2 speakers now. I would request Abhay to talk on complications, complications in management of US. And that would be followed by Bhavuk's lecture.
So the surgery, thank you, Dr. Johari. The surgery for early onset scoliosis is as perfect as the perfect man drawn by Leonardo da Vinci. It's full of problems, and the problems only get bigger to the extent that today I would call problems as a natural history. I think all of you would agree that scoliosis, early onset scoliosis, I heard Salil saying 50% complication rates. I'm going to quote my patient a 200% complication rate, which means that every patient of mine is going to have two outings that are slightly off from what I had planned, initially. And this is probably the only surgery that has survived such a high complication rate. So the problem for the EOS surgeon is that the surgery is riddled with a bad pitch to begin with. There's a variable clinical presentation. The whole bunch of people are getting grouped into the same pathology. And there's the unpredictability of growth. And of course, your patient is a really tiny, emaciated kid, especially in this part of the subcontinent. Kids have very poor skin cover. They are malnourished and they turn out, just like skin and bones, and they're the size of your palm, literally. They're significantly deformed because most of them come in pretty late. And of course, they invariably have multi-organ involvement. So the key question is to minimize your complication. You want to operate late, but then how early can you operate, right? So if you operate early, you're tempted because the curve is supple, you can get some good correction, and you can often work on lesser levels. And the more you wait for the child to develop and get stronger to take up this, big endeavor, the soft tissue covers gets better, and then the, bony points get better. So there are pros and cons of, operating early and operating late. But the dictum here would clearly be, there is a weight cutoff of about 12 or 14 kilos, depending on the institute that you work. But to minimize your complication as a general anesthesia risk and as a general patient risk, you want to delay surgery as much as possible. And I think that's the rule that will come out from all surgeons who operate for for early onset scoliosis. And that's where the role of casting comes in. And all of us should be able to do castings in a pretty professional manner. And it's an art that has been reinvented, and that's now got again in the mainstream. And everyone in every meeting is talking about castings. Now, the problem with surgery is that it's mostly done posteriorly, and posterior surgery, as you can imagine, in this, group of patients will have all these intuitive problems, skin breakdown because there's literally no skin, and this, your screw heads are going to be popping out. Progressive rotational deformity because growth rod eventually is just a distraction device. Autofusion because you touch a kid's spine and he starts to fuse. Implant loading problems because these are small implants, and of course the sagittal plane deformity. So let's take a few of them at a time, and I'm going to try and show you my cases and some of the solutions that I have worked around. So the first problem was skin complications related to the implant profile, which again is intuitive. There's no reason to not understand why you get skin complications. Even in the best of scenarios, you have these bulky implants popping out, and the tinier the kid that you operate, the more this implant profile. And you really worry when the child who the parent is very happy about because the child is straightened up after the EOS implant looks like that. But sometimes it can start getting very tricky, and especially at the top end you can have a rod popping out. These are all my cases. And then sometimes it can get plain ugly, and this can be a disaster. Of course, parents often underplay it, but that this child is heading for a big problem. Like this girl needed finally implant exit, a flap, and really badly scarred looking spine. You would hate to show this patient as yours in any meeting. The other strategy that you would use to minimize the prominence of the implant is do a single growth rod in the concavity, because concavity dips in, and especially the child is small. Even though we all believe in double growth rods, I think a single growth rod can be a bailout until the child grows up, and then you add another growth rod to this. There is a role of anterior surgery, and there was a question on the chat box about this. So this is something that my mentor, Dr. Bhojraj, has been practicing. If it's a very young kid with especially a lumbar hemivertebra, which is kyphosing, so you don't want to wait for too long, this sort of an anterior surgery can be done at a very early age. And literally low profile implants can be used this is actually a tension band wire, anterior enucleation. And this surgery can, hold the test of time. But remember, this is only possible when there's a localized apex. So you cannot try an anterior tether in a regular round back EOS. And for example, this child, also our case done, in the early 2000s, an anterior tether was tried, but see what happens as she grows up, they get a posterior crankshaft phenomenon. They start kyphosing, and this gets very, very difficult to treat after, after she presents to you with a deformity at adolescence. The other strategy, of course, is, I think all of you would use it, is in tiny kids. You can use cervical lateral mass screws because they're lowest profile. Of course, these are again good if there's an apical fusion in your gamete, and if it's a growing rod, sometimes these screws will not be good. I have used the Lukey trolley because a lot was written, and it is indeed a flat implant. It has the least profile, but it comes. So this is a child who was a non-walker who had multiple surgeries for meningomyelocele, and but as you see, as the Lukey trolley starts to expand, it starts to unlock from the wires, and the child starts to kyphose. And this child eventually landed up like this and needed a primary or a final fusion at an early age. We're still following her up, but she's all right. Another strategy again was mentioned was to try and get some implant some push down on the apex, because the place where the skin gives way is really the apex of the convexity, and you can see the screw sits out. So if you can control the apex, you can also help prevent the progression of rotational deformity. So the surgery that I normally like to do for a conventional growth rod is a surgery which starts with a convex rod which has an apical anchor, and you put a cantilever down on that rod, and then put your growth rod on the concave side. So you have tight screws at the apex, loose screws at the ends, which tends to grow. Of course, you have to leave the rod long, and that can be a problem because it can stick out from the skin. And then you do serial distraction on the concave side. So it's like a double barrel growth rod technique. It will also help correct deformity progression. And of course, sometimes this is what I do. I like a single long incision because I know that's the incision that's going to be a user-friendly incision for long. And through this, I do submuscular implants. So I try not to do periosteal dissection, and you do transmuscular implants to try and minimize the problem of autofusion. And this seems to have worked in my hands. Like, this is the last surgery we did like 2 months ago in Burundi, in the middle of Africa. Even there, we could get this so you see the two screws at the apex. So you always start with the easier rod. In this child, because the deformity was very severe, we started with the concave rod. We got it right. We could get the alignment right. Then we hazarded ourselves and got the convex rod, where again we did the top and bottom screws, and then finally got the apical screws in. Intraoperatively, of course, you can have difficulties when the presentation is quite hideous. You can have a problem with finding out where to put your screw. But I think most of you guys are experts at this. When I'm unable to do so, I resort to wires or to hooks or even claws, and sometimes rib-ilium constructs. And this is again early, 2008, I think you can see on the, it's a rib-ilium construct. They don't last too long, but they are good for a bailout. This guy had a scarred, apex, which had been operated before. So there was, I was quite perplexed to put in implants in this guy. So this seemed like a good extraspinal gizmo. We developed one with one of the local industry partners, but it's not really done so well because obviously this is a one-sided implant. It's at a flat profile, and I think the indications to use these kind of, we call it the Desi vector, are very, very minimum. So going from then, I've really not used this that commonly. And then the EOS complications of natural history, which means almost all your patients will go through this at some point or the other. Screw pullout or implant breakage, or screw pullout or rod pullout, rod backing out at the top or at the bottom is again one of the common complications. As you can imagine, the screw has very little hold, and there's a constant pull-out strength on that or pull-out force on that screw, especially at the top. So both these are very, very commonplace. And I counsel the parents that every third or fourth outing, you may need to, asides of the rod distraction, you may need to reset these, these. And one of the ways to deal with it, as everybody knows now, is to avoid a pure flat distraction, but to try and contour the rod in a way that the distraction area, the thoracolumbar junction, is nice and flat, so it can distract. But at the top and the bottom, you try and contour the rods, so there is less pull-out strength, less pull-out force there. And I think this is what is the take-home message from as far as this is concerned. Or else sometimes, if you are really worried, you can do a staged operation, get your anchors in, let them fuse, put some bone graft around it, and come back after 3 or 4 months and then put in your growth rod. implant breakage, these kids are monkeys, they just will not listen to anyone, and they are going to jump around, and your implants are compromised. They're thin rods. So again, implant breakage in my hands is almost a rule. And the good news is that after 3 or 4 outings or 5 outings, the child is also bigger, and you're able to put in bigger rods, and sometimes you can brace them if they're fine. The wound giveaways can be a disastrous complication, like this child who I showed earlier eventually has ended up with a short trunk because she's still very, very young, but we have to take off implants, treat her infection, wait, give these bad scars, and finally, give her a badly fused spine, if you may. So it can be a real problem. And finally, problems with planning the strategy. So this kid came with what looked like a progressive curve, which from age 1 to 2, again, here I was not so good at casting back then. I was not so sure of casting, and I was a bit bold about growing rods. So we went ahead and did a growth rod at an early age, which was still okay. But the signal that kept coming was that the rod kept backing out. Either the screws backed out or the rod backed out. And what I had missed was an apical hemivertebra that was posterior. And I had not done an adequate imaging preoperatively. And hence the child kept kyphosing, and that was the force that kept pulling back. And we found that out much later. And we did a late osteotomy, and we tried to harness the apex. So this is all like trying to clean up the mess that you have created. And because of so many outings, the child eventually had an infection. We tried to salvage, and eventually he's Arjun bailed me out with his fantastic cast, and the child is now on a cast. So this has gone in the reverse order because honestly of a surgeon error in planning the strategy. So today, if a child with a significant kyphosis comes in, I cut my losses and I offer them primary fusion. Here's another interesting case who presented with the L5 hemivertebra. And again, it was a tiny kid decompensating. So we went ahead and did a hemivertebra excision and a very short kind of a fusion with a wire. And he did well on that front, but he started developing his EOS after that on top, and then we had to add a growth rod. So as you can see, this surgery is riddled with problems, and these problems are they make you humble. Actually, as you see more and more of these surgeries, you realize that you can only do that much. The message out there is stay strong, because this is going to keep coming at you, and you got to keep rising to the occasion. And you will learn as you grow, as I have over so many years, and we learn from the experience of the masters. Thank you, Dr. Johari, and thank you, Arjun, for having us present here.
Thank you, Abhay, for being the problematic surgeon. I think excellent that you showed. It's not a field like a walkthrough field. You really need expertise to be able to handle early onset scoliosis. I'll now invite Bhavuk. Bhavuk is going to speak to us on syndromic scoliosis, early onset, and special considerations.
Thank you, Johari sir, and I thank ASI and Posi for giving me this opportunity. Am I visible and audible?
Yes.
Yeah. So I will be covering the syndromic scoliosis. And if we look at the definition of syndrome, it's basically a fixed, there are some fixed signs and symptoms and the pathologies which are occurring, more than one times, and the people have recognized that this is this can be linked to a single pathogenic, the pathogenic basis. Then they call it a syndrome. And when we talk about the spine surgery, we have some usual suspects when we look at the scoliosis. Like these are the cases, these are the syndromes which we know they present very commonly, like neurofibromatosis, Marfan's, Austen imperfecta, Ehlers-Danlos, Prader-Willi, familial dysautonomia, or the Relay syndrome. So these are fairly common, but sometimes we can recognize with their, the classical phenotype, the Marfan's and the neurofibromatosis. But then there are some, the syndromes which catches scoliosis, not as a usual finding, but as but they become important because they carry, some important surgical and the considerations, like the coagulation abnormalities, abnormal bone mineral density. So we have to be aware, and we have to be, very cautious. And the another thing is that you need a good genetic backup and the good genetic services at your institute. And this is a must if you are treating the syndromic scoliosis, because only then you can identify the basic pathology, and then you can label these syndromes, and then you can understand the basic pathophysiology behind these disorders. So this slide is true for every scoliosis, that you have to understand the disease, then you have to plan your management, and accordingly you perform your plan to avoid the complications, and then you assess the outcomes. So the general issues in syndromic scoliosis are, they are multifold. They can be related to cardiac, urogenital abnormalities, the neurological, the symptom. They have more higher incidence of, the neuraxial abnormalities, nutritional problems. They are fairly common, and they frequently require a coordination with your pediatric, the nutritional expert, and even the pediatric surgeons to put a gastrostomy tube, before to build up their nutritional backup. Ligamentous laxity becomes challenging, because they progress very rapidly, and the area of fusion and the area adjacent to your area of fusion becomes a problem fairly commonly in these syndromic patients. Coagulation abnormalities, they are again very common. The ocular problems, they are especially in Marfan syndrome, they are fairly common, and I always get the visual field documentation before the surgeries, because this can become a medical legal issue if the patients develop some visual problems, which are fairly common with any scoliosis the surgery. It is well reported. So then you have something to back up that there was a pre-existing problem, and what is the new thing which has occurred after the surgery. Dental abnormalities again become very important, like an osteosis imperfecta. Putting tubes when the discussion with anesthetist becomes important. Wound healing is often a concern. And then there are other orthopedic issues like the developmental dysplasia of hip and the shortening of the limb that also affects your surgical planning. So one has to be very careful, and this requires a multidisciplinary support. And the preparing for surgery of these patients, it requires a multidisciplinary care. I'm not going to detail. I will be just covering the surgical the points related to the syndromic scoliosis as a spine surgeon, what we face. The casting and bracing, it requires very judicious use, and they are a great friend when you're dealing with the syndromic patients to delay the surgery. As Dr. Salil pointed out, that we need to delay these surgeries at least, if we can delay it by 60 years at least, then we can get good outcome with the help of the growth rods or the other modalities of surgical treatment. The casting and bracing remains an issue, because like in osteosis imperfecta, if you do this casting, then the rib deformation, it also is a problem. And then there's a thing called valley effect. That means the ribs, they ballooned out posteriorly, and your spine goes into lordosis. So that becomes a very challenging to put screws, in these cases. So this has to be kept in mind, and they need to be followed up very carefully. Hallograft retraction is again a good friend in certain cases, like in neurofibromatosis, sharp angular kyphosis, and like in this. And my indications remains that if these patients, they come to me with as a respiratory compromise, and if there is a pre-op neurological compromise, you have to study their CT scans very carefully. And if you see any rib penetration to the canal, then this is a contraindication, and one has to be very careful, and one should be aware of this problem in neurofibromatosis. Like in this case, you can see here a very severe scoliosis with neurofibromatosis, and this we Dr. Abhay pointed out that in sharp such kyphosis we had to go for primary fusion. So I also went for the primary fusion, and these patients, they, once you fix them, once you give them a good spine to as a foundation, then they recover nutritionally as well as in the respiratory. They are everything improve, and you can see the gross difference in the body build after the surgery within 2 years. Now, when we are dealing with these syndromic patients, we should be aware of the abnormal anatomy. Now, as a spine surgeons, when we think of the abnormal anatomy, our mind usually goes towards the bony anatomy itself. But the soft tissue anatomy is very, very important. I would like to show you a case of Ehlers-Danlos syndrome. When these have very large vessels, and the anterior surgery is frequently contraindicated in these cases. Like in this case, you can see even from the posterior side, there was the arch of aorta. It was very near to the transverse processes, and you can see here that if you are not careful, then while dissecting itself, you can injure the aorta. So one has to be very careful, and you have to look every subtle signs, even when the exposure becomes a challenging problem in these cases. Now, the bony anatomy itself, especially in dystrophic varieties of neurofibromatosis, like in this case, it becomes quite challenging. And if you look at the CT scan, besides the dural ectasia, the abnormal pedicles, you can see that the whole of the vertebra is extruded out from the normal canal. So these sort of cases, they require special planning. There is no doubt that this requires the excision of this vertebra, but doing it from the posterior approach alone is not possible because of the lumbar spine and it's the nerve root. So this requires combined, the anterior and posterior VCR. So these cases, again, they become challenging and they require, the flexibility in your approach and your flexibility in your surgical techniques, so that, you can deal. This is you can see here the classical dural ectasia producing the almost non-negotiable pedicles, and they require these special. So we did it from the front approach. We approached it. There was an ilolumbar vein. We had to ligate it. Then we took it out vertebra. Then we went posteriorly. We corrected the deformity, completed the VCR. But again, there was a challenge to restore the coronal balance, because the whole of the spine was shifted to one side. Then we had to use this kickstand screw technique as popularized by Lenke, and then we could get a decent outcome in the coronal and the sagittal balance. And this is the post-operative pictures. Now, these cases, some of these cases like MAF1, Ehlers-Danlos, they have, the flexibility, and this flexibility may not be friendly always, because it becomes quite challenging to put your screw. So this is like a technique which I use. I use the screw in the adjacent segment. I keep the handle intact, and then you can use it as a the stabilizing agent, and then you can use this you can put the screws, or you can make track in the adjacent segments, and that's how we proceed this thing. So this becomes quite challenging. Flexibility may not be friendly always, and this is a useful technique, especially in syndromic cases. And this is the same case. You can see here the good correction which you can get in this case. The fluoroscopic guided navigations, the O-arm guided navigation is a very useful tool, especially in these syndromic cases like in neurofibromatosis. And the robotic assisted pedicle screw placement is also, you have to be very, you should be knowing what you are doing and how to use the robot perfectly, especially when the things they are moving into the cervical spine, the deformity is moving to cervical spine. The robot I find more useful than the O-arm in syndromic cases when there's flexibility too much. Then the robot itself actually tell you that the navigation is actually going to the right direction or not. 3D printed models, they also helps you in understanding, and you can keep these 3D printed models on the table, and you can look at the actual anatomy at the time of surgeries. The 3D printed drill guides, again, they are quite useful, and we have published it. Now, the pedicle screws, they are although the main workhorse, but they may not be feasible always, as Dr. Abhay also pointed out. And then these dumbbell sort of, these protrusion into the neural foramina, they also tells us that there is no way that you can put pedicular screw either neither the extrapedicular or the intrapedicular the inside the pedicle. So these becomes very challenging, and you have to think of the other alternatives like sublaminar wires and the hooks. You can see here we have used in this neurofibromatosis case. Again, another case, and the hooks, they are again very friendly, and if you use properly with judicious releases, they can give you a very good outcome, like in this case. The another case of using just the hooks, you can see that I have used the hooks in various in the various forms, to making a claw, and we are using it for the maximum advantage, so that we can get the good correction. Now, the other thing is, like nowadays we are using a lot of laminar screws, in fact the thoracic laminar screws, and we have found it very useful. And you can see here this case, like this is a scoliosis case, and the pedicles, the concave pedicles, they were not perfect to put the screws. So we use these laminar screws at the apex, and then we apply this rod. We use 2 dominoes, and then we use these the reducers, and then it derotates as well as it reduces. And this is the correction you can see here, and this is the x-rays pre and the post-op, just using the laminar screws. So again, these laminar screws, and we have actually got the grant from the government for developing these laminar screw systems. Cervical, these syndromic scoliosis, they also have the frequent their extension into the cervical spine as well. And if you are correcting a deformity, then you need to know how to put these cervical pedicular screws. And the pediatric age group cervical pedicular screws, again, they are quite safe, and we have published this paper, and they are quite safe. Now, this is an example of a syndromic case. You can see here that there is a T1 tilt, and the deformity is quite into the cervical spine. And the putting pedicular screws, again, it becomes quite challenging, even with the navigation, because the trajectory of the screws, they are quite outside. And then you have to think of some innovative techniques that how to deal with these cases. And these syndromes, if you look at it clinically, then you can see that something is off, and then you should always be picking up these syndromic cases. So in this, we use a combination of the pedicular screws and the laminar screws to derotate the spine proximally, and we could get a good outcome. You can see here in this child. Another case of very syndromic scoliosis, you have to be thinking, you have to be examining each and every part, and this is a case, which progressed very rapidly within 2 years. And then when we looked into the CT scans, you can see here that there is a almost 180-degree rotation just within 2 vertebrae. So from D4 it is rotated in this direction, and D6 is rotated in this direction. So this becomes quite challenging, that how to derotate such close this thing. So and this is the post-op. You can see here that I have connected the screws which are rotated into the same direction, and then we use the different rods, and then we derotated them in the same direction. So again, these require special planning, and this is the post-operative correction. You can see this technique. Now, these cases, they are often neglected, and they present with very severe deformity, especially these neurofibromatosis cases. And to getting these cases, they require the vertebral column resection, and there is no point of using the growth-friendly techniques in these cases. You have to go for primary surgery in these cases. This came to us with spastic paraplegia, and this becomes quite challenging. And these require some modification of the traditional VCR. So we published this technique called modified posterior vertebral column resection, and in this we retain the posterior elements till the end, so that the cord remains quite the healthy, because it is hanging from the epidural veins from the posterior elements, and you complete the VCR first. So this is quite healthy, and this has we have not seen a single case of neurological deterioration till now in our series. So this was a case, and this we could get. So again, you have to see that you have to. So in this case, you have to, your armamentarium of your instruments and the implants, they should be everything should be available. 3.5 millimeter system, 4.5 millimeter systems, cobalt chrome rods, the tapered rods. So everything we have used in this implant, various types of dominoes which are connecting 3.5 to 4.5 mm system, 4.5 mm to a 5.5 mm system. So everything should be on the table, because my aim remains to use the maximum diameter rod possible in these cases. Don't shy from staging. We have seen the previous speakers also. So if you're doubtful about the bone density and during the surgery, it is always useful to use the staging. Let the anchors fuse first, and then after 3 months or maybe 6 months, then you go ahead and then you apply these growth rods. Now this is a technique. This is an implant which we have devised. We have called it as a rib screw, and so just a single exposure. The single level exposure gives you actually the 4 points of fixation. You can see here, and we call it as a Falcon construct, and this is a patented technology from our institute, and we are using it a lot, and this has given us a very good the outcomes in the early onset scoliosis patients. Again, these cases, they require a lot of wound healing problems, the repeated surgery. So again, a collaboration with your plastic surgeon is very, very important, and they remains a very important part of your practice. But basically, all these cases, they are a teamwork, and I would say that a surgeon, we should always approach the syndromic curves with a flexible mind, and we should be looking at every spectrum, every part of the spectrum which these kids they present to us. Thank you.
Well, thank you, Babu. As such, EOS is difficult, but syndromic EOS is horrible, horrendous sort of area to deal with, So you have my sympathies and appreciation for what you're doing, We really are short of time, any burning question you may have. I think there are a lot of questions on the chat box. Shyam has answered some of those. Any other questions, 1 or 2 questions we can take before I just close this webinar? I think this webinar has been so interesting. We didn't know how the time has passed, and I would request for a complete case discussion session in the ASSI conference, on EOS. That would be the part 2 of the webinar. Sudhir, please go ahead.
Sir, can I ask question?
Please go ahead. Go ahead, Vijay.
Yeah. So those who are attending this webinar, I must say about Dr. Ashok Johari. He's a pioneer scoliosis surgeon. Even when I was practicing general orthopedic in 1998, he used to conduct the workshop on scoliosis, full day workshop. That was time when I attended sir's workshop, and at that time he's one of the pioneer pediatric orthopedic surgeon as well to start the work of scoliosis in India. So thank you, sir, for being organizing this such a wonderful webinar, and thanks to Arjun also, and thanks to all SC faculties. There are a couple of questions. First question is to Ashish. Ashish is here. Ashish Ranade. Okay, so
Ashish is
Ashish,
there.
yeah. So now regarding the early onset scoliosis, the what you are talk about the pathophysiology, is there any difference in terms of adolescent idiopathic scoliosis or maybe children with neuromuscular like spastic scoliosis? Any subtle difference you find in pathophysiology?
So, Viraj, I understand you are asking, is there any difference between idiopathic early onset
Yeah,
versus
yeah, yeah.
neuromuscular? We are not seeing many idiopathic or infantile scoliosis per se. We are seeing mostly either syndromic, congenital, or neuromuscular. And in addition to the lung pathologies, they have other issues such as poor nutrition and so forth, so on. So, in my opinion, the complexity is higher than the idiopathics, where it is there is no added sort of pathological problem.
Okay. A quick question to Dr. Naresh Babu. Sir, how do you tackle those children who are presenting little earlier, maybe less than 2 years, to take the X-rays, because we are not able to take the standing X-rays. So how do you tackle that problem? Any practical tip?
That's what I mentioned in the talk initially. If you can't take a standing view, but we need to have a loading effect, upright effect, how the spine is behaving on the loads. So one way is to get a sitting X-ray. The sitting X-ray can be easily done with a radiolucent table. Patient can be strapped onto the chair, and we can have AP and lateral views in the sitting X-ray. But supporting and getting it standard is quite okay in a very little children, around 2 years. But if a patient is a neuromuscular patient with developmental delays, it becomes really difficult to get a standing view. But spine can be really assessed. The loading effect can be assessed with a decent sitting X-ray with custom-made tables, chairs, I mean.
Okay.
Viraj,
Thank you.
Dr. Srivastava wants to ask a question. I think we just give him
Yes,
the floor.
Actually, this question is to just ask to different pediatric spine surgeons. Do you find any difference in neuromonitoring? In pediatric age group, these patients and adult spinal deformity. So, any difference in the neuromonitoring you have noticed?
So, Babu, would you want to answer that?
Yeah, sure, sir. So yes, pediatric neuromonitoring becomes a challenging issue, and we are working a lot in this thing. The other thing, the important thing is that we are using the TIVA, the intravenous anesthesia, but to maintain the concentration of these the anesthetists, it becomes a challenging issue. So that's why we are using now the TCI pumps. We call it the targeted control infusion pumps, so that we can maintain the adequate concentration. So basically getting the baseline signals before starting the surgery and determining the exact concentration becomes very, very important in these pediatric age groups. And we have good neuromonitoring, the experts and the anesthetists. So a good collaboration between them is very essential. The other thing is, which we are now going to venture into, is called the functional near infrared spectroscopy. So this is like a 36 channel, the cap which you wear on the pediatric pediatric patient, and then you can monitor the activity of the each the frontal cortex, this thing, and then you can look at the actual concentration which is required for the pediatric patient, and the best concentration for the neuromonitoring things. So a lot of things are happening, but they're not but yes, definitely it is a little bit challenging than as compared to the adult patient.
Thank you.
Well, thank you. Viraj, we come back to you, but just one burning question because we need to end the webinar.
Yes, sir.
It's a time-bound thing.
Yeah. So, Dr. Shyam Kishan, a wonderful presentation. Just if you make a large windows, so do they have any chance of going back into the rotation?
The windows help with the derotation of the spine. So you take away any part of the cast that you don't need to push on the body. That's how I started doing these. I learned casting from Jim Sanders and Min Mehta. That's how I started. And for a while, I was not in Min Mehta's good books because she thought I made too many big windows and I was using fiberglass for casting. But I found that the larger the windows are, the more the spine and the chest can derotate out. So it's never been a problem. In fact, I don't even, you will be able to palpate the entire spine in all of my casts, because the cast only supports the rib on the convexity. So the spine is allowed to kind of roll out of the cast, if you will.
Thank you.
Well, there were other questions to Shyam, but I think he's answered them on the chat box. These were dealing with neurological deterioration when casting or after casting, and the time between cast and duration. So that's the answers are there on the chat box. Any questions for Ajay and Abhay?
I had a question for Salil. So Salil, typically at what age do you sort of make that shift, of gear to the growth rod? I mean, how are you able to sort of take that call?
Yeah, most of the time it's somewhere between 5 and 6 years of age. I try to delay as much as possible, like most of the speakers were mentioning. There are some kids that have to have it at a much earlier age, 2 or 3, and in those you just have to be a little bit more aggressive in driving their growth. So I have had to use a single magnetic rod temporarily until they get big enough to insert the second one. So you use different strategies to minimize the number of surgeries that they're getting, but still drive their spine to control their deformity.
And the oldest, like the oldest you'll do it.
Yeah, I just looked back at my series for this talk, and I do have an 11-year-old, which I'm ashamed to say, but very short trunk. So that child did need, or I felt that the child needed a growing rod. But nowadays, I think the older age is getting cut down quite a bit. So somewhere between 8 and 10.
And Dr. Kishan, what is your sort of interval between castings usually? I mean, average.
So I don't have a magic formula. I let the cast stay on for as long as possible. I don't believe in frequent cast changes. I let the child grow as much as possible. So the things I tell the parents that they have to watch out for are, if the child is not able to eat as much as they eat normally, and they're having to eat more frequently, it means that the cast is getting snug on their bellies. So that is one sign that I use to change the cast out. But on an average, probably the casts don't get changed for about between 4 to 6 months at a time.
For Dr. Shetty, like, is there a weight threshold where you would do a hemivertebrectomy? Like, is there a weight cutoff you have?
Specific as such, I do not look at a specific weight, but I would look at the overall, how is the skin of the child, whether there's adequate soft tissue, whether I can cover the implant. I do not look at, because hemivertebrectomy as such is not a very significant procedure. The amount of blood loss is significantly lesser if you are going to do at one level. I look at overall development of the child rather than a particular weight, as you do a deformity correction when you are looking at a whole length.
Any questions for Abhay? I think with lower profile implants, Abhay, I think some of these complications could be obviated, So, of course, depends on what we can use, in the particular case. But definitely these are complications, May not be the whole rod, but the hook or the screw, end of that may become very prominent and eventually cut out. Shyam, go ahead.
So something just for Dr. Srivastava, he was asking about neuromonitoring. One of the things that we've been doing now, that I've been doing for the last about 10 years, is we follow a protocol called an ERAS protocol. ERAS is Enhanced Recovery After Surgery. And I prep them for their pain management before surgery. So all my spine patients come to the operating room. They've been dosed preoperatively with celecoxib, gabapentin, Valium, and a scopolamine patch. The goal of all of this is to reduce the intraoperative and postoperative narcotic use. And then the anesthesiologists know very well how to tailor the medication. So we try to keep it very low on medications that alter your neuromonitoring. So very low gas if possible, maybe gas just for induction, and maybe a little bit of paralytic just to help exposure. But they keep it primarily on propofol and ketamine with minimal Presidex, which is dexmedetomidine. So after I expose, as soon as I can put in intrathecal Duromorph, I will put in about 5 mics per kilo of Duromorph into the spinal fluid. and after that, the child does not get any more parenteral narcotic. So these sorts of things that reduce the amount of anesthetic that you use, and of course, TIVA, as has been talked about in the presentations earlier, they have really changed the anesthetic load. And Bhavuk was talking about using BIS monitors. I've used all of those things, but I find that the amount of anesthetic, the total amount of anesthetic that a child needs is significantly decreased if you address all of this preoperatively. I don't know if anybody else is using ERAS protocols here.
I think Bhavuk mentioned something about that.
Yes, we are using ERAS protocols, I was not talking about BIS thing. I am talking about the functional near spectroscopy, so that you can look at the activity of the cortex, and then you can decide the concentration of the anesthetist. The only thing remains that you have to, be at the ideal concentration of the anesthetist. So that's how you can get it. It is between anesthetist and the neurophysiologist.
Bhavuk, any word, you spoke on syndromic scoliosis, any word on the morbidity, mortality, or your own experience?
So the morbidity is definitely higher in these kids. There's no doubt about it. But again, if you go, the multidisciplinary approach, then again it can be minimized. Mortality is definitely, if we look at the general population, it is definitely higher in these age group. But I haven't found anything in my general follow-up, the mortality in these age groups.
Okay. So thank you. I think it is time to end, Arjun.
Yeah, so
I think we should be ending now. I would just like to sum up, that we are all treading in a very difficult area where the path is not clear, things are so uncertain, and however well you plan, you can still land up with problems, So decisions have to be based case by case, and whatever best you think or whatever is the optimum treatment for that particular patient at that point in time, So very challenging field, and the experts who presented here really brought out each area very, very clearly and very lucidly. And I must compliment them. I must compliment ASSI and POSI both for having this webinar. It's a timely sort of alarm call, that this requires more coordinated management between different specialties, multidisciplinary management, and long-term, keeping the long-term in mind is very, very important. So thank you all for being here today on a Sunday morning and enlightening us with your vast knowledge. I think if we were to add up the combined knowledge, or experience, it's more than probably 150 or 200 years, 7 speakers, well, each practicing for 20, 30 years would mean a lot of experience in this particular webinar. So thank you all. Thank you, everyone. I would like to end the webinar. I think the case discussions, we leave it for the actual conference, for a session in the actual conference. Thank you, everyone.
Thank you, sir. Thank you.
Arjun, when we stop recording?
Yes, thank you. Thank you all.
Thank you.
Thank you. So we can say bye to each other.
Dr.
And
Srivastava,
get on with our
like to
Sunday.
speak?
Thank you. It was a wonderful session, and we really appreciate everyone talking so nicely. Wealth of information we got it today, and thanks POSI, all the faculties were excellent, and ASSI really appreciate their efforts, joint effort, and as suggested by Dr. Johari, we should do this frequently. Thank you very much. Thanks a lot.
Thank you.
Thank you.
Thanks to all faculties. Thank you. Thank you.
We close the meeting.
Yes.